Okay, we will now move to the public comment period, and we have 4 individuals who have signed up to offer their comments, and I'd like to begin with David Magnus and ask each of the commentators to limit their comments to 4 minutes, no more than 4 minutes. You did not? You're on the list. All right. Okay.
I actually didn't think I signed up for this. So, okay, but I'll just want to point out one thing that amplifies the comment I made earlier about being clear about risk, and that's about one other thing, which is sometimes when people are talking about these differences, it's really important to distinguish between variation in utility assignment from risk. So when people are talking about the difference between toe pain versus headache, again, if risk is the product of the probability and magnitude of harm, you can have comparable risks, or the risks be the same, even if outcomes are different, and the utilities that people assign to them will vary. And so those may be very important in the consent process, but that doesn't necessarily transform them into risks.
Okay. Thank you. The next individual is John Wilbanks. The next one is Sharon Terry.
Thanks very much. I'm going to introduce myself just so that it's on the record. So I'm primarily here because I'm a mom. I have 2 kids who are adult children now, who have a genetic condition, and that's why I came from my chaplaincy and campus ministry into this field 19 years ago. I'm running a coalition, which is a network of disease organizations and other health organizations, and as such run quite a number of coalitions. One of the activities we just engaged in is putting together a letter to ask for an extension, because it's far too quick for us to digest everything from this meeting and for us to assimilate responses from a broader community in such a short time. And so that was delivered to the secretary last week, and it had 200 organizations signed on. So I really love the diverse perspectives we have here, because this is a microcosm of what we're trying to address in the world today, of different kinds of feelings and sensibilities. And we're trying to use non-dynamic and old world solutions, and we've heard a little bit about that today. These structures that we're trying to apply to this were crafted 20, 30, 40 years ago and don't apply in a world that's networked with a very broken healthcare system. We're looking for a culture shift, and we are looking for a time when we're not subjects, but we're participants, albeit with rigorous standards for evidence and that are upheld and improved. We need to be engaged, not consented. Consent is burdened, and it doesn't uphold or doesn't kind of underlie what we need it to today. That has to be done in a trust context, and it no longer needs to be expensive or complicated the way it used to be. There's a number of systems today that are actually experimenting with this. So PCORNet, Collaboratory, Mini-Sentinel, CTSAs, you've heard about a lot of them. It's time to ramp this up. Specific to this workshop, I have 2 points. One, risk is not harm, and we did hear that a number of ways. We already have harm, we live with disease, we live with disability. Those who have not yet crossed that line may not experience that yet, but we all will. We know that lives have been lost because of how we do business. It's certainly contextual and perceived differently when you cross the line. Consent is overburdened, as I said. It's a transaction, and people want engagement in their lives. I'm not suggesting we throw consent out, but it needs to be put in its place. There are already dynamic and granular systems. I run one such system called Platform for Engaging Everyone Responsibly. It is dynamic, it's granular, it allows yes and no and even maybe. I know that I can hear the clutch in the gut of researchers when I talk about this system, because they don't want complexity added to complexity. But we are again seeing Google, Facebook, Waze, Twitter, all randomizing, all doing these kinds of things every day in very granular and dynamic ways, and we can adopt those ways. We need to broaden the workforce. It should not be just researchers or hospital administrators trying to figure these things out, or IRBs. It should be everybody. It should be participants, clinicians, and so on. We're the ignored players, and we have a lot to offer. For OHRP specifically, I think OHRP cannot be vague and imprecise in this guidance. It cannot imply that anything measurable is a potential risk. Not everything is a foreseeable risk. And it must focus on benefit, not just risk. We're in a risk-averse culture, and it seems that OHRP might be caving to that. Overall, we need not to waste the experiences of people who are treated and cared for. The systems need to learn themselves. We need to let us, all of us, know what we don't know and that we don't know. We are part of the solution as well. There is an opportunity for the people who care deeply about the standard of care and other research to work together, to engage one another, and offer a viable alternative here. We need the grass tops, those are the thought leaders, like all of you in the room, and the grassroots, which are all the people who are suffering, to work together to create a movement that will create better treatments and care. Thank you.
And the last person on the list is Cindy Gagan.
So I am here not to comment myself, but to, well, I'm going to read comments on behalf of Nancy Roach, who was here yesterday and who did sign up to make comments. And just to introduce Nancy and myself, we represent not just individual patients in this room, but as Sharon just said, the collective experience of a lot of people who've been working in this who may not have published literature on it, but we represent the perspectives of many patients as patient advocates. And you will hear that when I read Nancy's comments, because they are very, very similar to Sharon's, and I know they didn't write them together. Okay. Nancy Roach is the founder and president of FightColorectalCancer.org, and she is now up at the NIH in Bethesda on a working group to represent patients, and that's why she's not here this morning. So I'll read her statement. Patients and subjects are concerned that there was not a single patient speaker presentation during this two-day workshop where several people, some of them very willingly and effectively, chose to theoretically present as patients themselves. It sends a disturbing message that the patient perspective is not important in developing guidance that theoretically is being developed to protect patients. I also want to thank the speakers who did make a point of emphasizing the need for the patient voice perspective, particularly during this morning's sessions as well as the presentations late yesterday related to preliminary findings from patient surveys that will potentially inform this topic in the future. To summarize and emphasize what many patient advocates and the heads of patient organizations with long and productive experiences supporting patients, helping to design trials, consent forms, consenting patients, and we would like our experiences reflected, even though we have not published results on our experiences. 1, protection does matter, but how much is important to patients and when is also important. Protection that matters to patients is what matters. 2, patient choice is important. Decision-making needs to be maintained, but the reality is that for many patients, decision-making doesn't exist now in clinical care. 3, we need to scrutinize what happens, how consistently, and what really constitutes standards of care, and identify those areas where serious inconsistencies exist. 4, we need to find solutions, and we need to maintain the momentum and speed of research. Patients want and need answers sooner rather than later. Patients need to be informed truthfully and transparently. They need to be informed that they have a choice about whether to participate in research, but they also need to know when you don't know which treatments are best, and that there might be more benefit or risk to some of what we don't know about. They need to know that they have the choice to participate in a specific study that might help answer those questions. Most important, we need balance, solutions, and a framework that is flexible and based in the real world and the realities of research today, including a learning healthcare system. Finally, and this was reflected in Sharon's comments, public comments in our patient communities are suggesting that the deadline for comments on this guidance may not allow for the appropriate time frame for meaningful stakeholder input. This input is critical if this guidance is to move forward. And if the patient voice was not recorded here, we ask that the time frame for comments to be extended and a request to see a plan for how the important patient stakeholder input will be incorporated. Thank you.
Thank you.